especially just for us. All the needs that we were able to collectively help line up for them last week, brought them back up from Wilmington. So we're grateful that you guys made the drive again, and we're also here for the new folks to hear your story and hear it all. So, Judy?
Thank you so very much. I appreciate you. And I just want to say thank you for bringing it back a second time. We had an amazing time last week when we came. Was it really just last week? It was really last Wednesday? Yeah. That is crazy. So much has happened since last Wednesday, and as a result of the folks who came to our last presentation, we've gotten so many connections, and you guys are truly awesome. 1 Million Cups is a very special ecosystem. Not only do we get introductions, but they went so far as to do research, to drop graphs into these presentations, into their emails. They personally went out of their way. It was amazing. So thank you so much for the response we got for the folks who came last week and came back this week. I just want to take a second, too, to have everybody stand up for just 1 moment. You can sit for a little while. I just want you to shake it off a little bit. Shake it off. I'm really glad you guys came, and I hope you will be, too. Now you can go ahead and sit down. You can sit down. Okay. I'm going to not block the presentation for you. How does that sound? And I'm going to take this off, too, since it's getting hot in here. So thank you so very much for coming out. We appreciate you. Before we get too far along, I wanted to introduce you to the team, and I'm going to put my ask out there up front because I was told that would be a good idea. So who we brought with us today is our co-founder and CTO, Stan Martin. He's going to be operating the technology to make sure the IT works. We have Dr. Dave McQueen. He's a psychologist leading the wearable portion of our project. We have Matt and Colton right here in the middle of the room. They are data scientists on our team. We also have Dr. Douglas Waltrip, who wasn't able to come with us today, but he's a medical doctor and the head of psychiatry in Hanover. Was also at Walter Reed Medical Center at the Pentagon. So we got a pretty sweet team. That's part of our core team. My name is David Reeser. I'm one of the co-founders. I'm the CEO, which just means facilitator. Just trying to help things go along. We got a lot of smart people. Our ask today, and I'm going to have two asks. I try to make it one. But our ask today is we want to be connected with progressive drug rehab centers. The groups that are doing MAT, medication-assisted therapy, and they're progressive. They want to bring new technologies in. They're very interested in improving outcomes for our neighbors. And I'll tell you who our neighbors are. They want to help those folks who are struggling with opioid addiction, and they're committed to it. They're voting with their time, with their wallet, and with their business to do so. The other folks that we're looking to get in front of are companies who are developing similar technologies who are also interested in ending addiction, either with innovative drug products, screening tools, whatever that they're developing. The technology that we're developing would be a nice complementary feature to what they're already doing. So we can walk through this with another company, if that makes sense. And I hope that it does. Excellent. Thank you so very much. So OpiAID, for those of you who don't know, is my volume okay in the back? Is it too loud? Because you're going to realize once I get going, I'm like a train, okay? And I'm really passionate about what we're talking about. I truly care. So OpiAID is an AI-based platform, as you see the name, to aid in the fight against opioid abuse. We didn't call it OpiSolve, because we don't believe that we can solve the issue, but we can aid in the fight against opioid abuse. We believe that if any individual person or company could have solved this problem already, or the government, they would have done it already. We believe it takes a community. So we're creating a community in the city of Wilmington, North Carolina, which has a very big problem with opioid addiction. We're creating an ecosystem where we can be successful. We've invited rehab centers to the table, civic and faith-based groups, the DA's office, the government, the drug court, even our neighbors to the table in order to create a solution that's going to work. Flip to the next slide. So the opioid problem is obviously a really big issue. I don't think there's anybody in the room that would argue that to be the case. But you may not know, I'll just do 5-second plays between the slides. There's just some random facts for you to look at. That what it's costing just our nation, just the United States of America, is somewhere around $500 billion a year. Just let that sink in for a moment. We spend $500 billion a year combating opioid addiction in this country. And last year alone, over 70,000 people died of overdose. So it's so bad, in fact, that you have a better chance of dying of overdose than you do in a car accident. Did you know that? We have a major problem. So what are we doing about it? My belief, you can stay right there, my belief is that we're doing a lot. It's just not as coordinated as it could be, and it's definitely not data-driven. I believe that we're winning a lot of battles, but we're ultimately losing the war against opioid abuse, and the numbers prove it. There are a lot of individual partners, as we'll describe. You can flip to the next slide. Thank you. So in the fight against opioid abuse, we see that there's really two parties. There are partners and there are neighbors. I referred to neighbors before. Neighbors are all those who are personally struggling with the disease of opioid addiction. They're our neighbors. So we believe that there are two major components that are causing the issue of opioid addiction to become wildly out of control. One is folks don't seek attention. They don't seek the care that they need, right? And it's because of the stigma. People are afraid to get help. They feel like it's a moral failing that they have a problem, that they have this addiction. That somehow it's something wrong with them, right? When in reality it's just a physiological response. Anyone can get addicted to an opioid drug. Not that everyone will, but anyone can get addicted to opioid drug within 5 days. It's not a moral failing, it's a physiological response. But when you feel as if you've done something wrong and you feel shameful about it, you don't get the help that you need. No one can help you until you want help, regardless of what the situation is, but particularly with opioid abuse. So one thing that we aim to do with OpiAID is to take away the stigma around opioid abuse by changing the way that we even talk about it. Words have power. So when we call people addict, which you'll never hear me say, I mean, you just heard me say it, so I guess I already want to get something. We don't talk about addicts, and we talk about recovering addicts. What we say is our neighbors in recovery. We take away that powerful stigma around it and the ecosystem that we create around it, even the way that we're developing our product. It's with our neighbors in mind, to respect their dignity, to create a conversation of compassion around technology and the way that we use it to improve their lives. Everything that we do at OpiAID is to improve the lives of our neighbors. We literally look at someone and say, will this improve the life of my neighbor, yes or no? If it's no, it's out the door. That's how important it is to us. The other problem is the fact that our partners, and that's everyone in the fight against opioid abuse. What's that? Are you kidding me? I got a little excited. I lost track of time. I told you I told myself for a reason. I'm going to skip through a little fast. Partners are everyone in the fight against opioid abuse. It's rehab centers, hospitals, civic and faith-based groups. We're working with them to leverage data science, which they're not doing right now, to better understand how we can use the information that everyone's collecting to find those patterns that will reveal key factors in who's recovering well and who's not, so we can create custom treatment plans to help our neighbors. Flip to the next slide. So data science and a wearable. Next slide. Thank you. So we believe that using data science, predictive analytics, will create customized treatment plans that will improve outcomes for our neighbors. And using a wearable device, we'll be able to get real biometric data in real time to be able to understand how people are recovering when they're back in their normal environment. Because what we don't know right now is when people leave an intensive 28-day program, how are they doing? The only way you truly find out is when they come back and have to be evaluated. You can call them up, but it's all subjective. If we objectively know how they're feeling, we can see the stressors, we can see that they're craving from a distance, we can intervene faster. We can actually have rapid response technology so that we can get them help right when they need it. Prevent a relapse, prevent a death. Skip the next. You've seen this before, go back. This is super fun. The Matrix guys, data science in the movies. Flip. Data science for real. We're part of the Google Cloud startup program. So we're in the startup ecosystem. We leverage Google Cloud, Superset, TensorFlow, Jupyter, in order to create data visualizations and do some real powerful things with the data. Flip to the next slide. Like this. This is a data visualization. And what visualizations like this do for opioid addiction is it helps guide policymakers, for instance, on what's real and what's not, and can even help with clinical decision making when you really know what the underlying correlating factors are to somebody's recovery. Next slide. Can we skip? Yeah, keep going. Keep going. So what we're doing this summer is we're validating our sensor array and the measurements that we're looking to take in cooperation with UNCW, the Human Performance Lab. We put in for an SBIR NIH grant to study our strength band, which was coined by the good Dr. McQueen. He's leading the wearable project. And the first step, which is an accelerometer that clips to your shoe. What we believe is that this summer we'll be able to identify these unique measurements that look like craving, that look like overdose, so we can remotely monitor folks to the level which they're comfortable in order to save some lives. And as I mentioned before, our ask, since we're running out of time, is to have introductions into programs doing medication-assisted therapy, progressive rehab programs that are ones to embrace companies like ours, and also work with other companies who are developing similar technologies or other complementary features that would tailor nicely or dovetail nicely with what we're doing so that we can go out and help some neighbors. That's all I got for you. I thank you for your time.
Okay, we've got one question up there, Jim.
Yes.
Yeah, since you are partnering with religious faith-based organizations, what percentage or what is the religious component of stigma and shame?
I don't propose that there's a religious component to stigma or shame. The reason I said civic and faith-based communities is that that's part of the ecosystem. So particularly in Wilmington, we have the Refuge and several other organizations that are creating living or homes for our neighbors to live in. And if they're part of the ecosystem, they need to be at the table. So we don't exclude anyone. That's the point. So they're helping them, and they have their own understanding of how to help them, and that's perfectly fine. But if we can also assist them with technology to take it to a new level, and also to hear what's important to the folks that they're helping, what turns them away and why people may not adopt it, that decide to go through like a refuge house through the church, and what would be appealing to them. But if you don't have everybody at the table, it's pretty hard to get consensus on that.
Right. Well, how are you addressing the stigma/shame component?
One, like, as I mentioned with the verbiage that we use, we don't say addict. Two, we're addressing it with how we're developing the strength band. It's not going to be an ankle bracelet like you get when you're going to prison, or to keep you from getting too far from your home. So it's going to be completely voluntary, but at the same time it will be discreet. Because while they don't want to broadcast that I'm in recovery, they also shouldn't be ashamed of it. So we're trying to ride that line. And it's even the way that we implement, the way we institute and share data. So if they don't feel comfortable that they feel like they're going to be labeled, they'll have up to 12 different options on the data sharing, whether they want to share their location or not. Do they want to share, with their family or not? Because maybe they do have some stigma about who knows about that, and we don't want to compromise this. Like I said, everything comes down to one simple question: will this help my neighbor or will it not? And if the question is for this particular our neighbor, it's no, then we don't do it. So that's the idea of the stigma. We don't want to accelerate the stigma in any way. We want to try to diffuse it, but we realize we can't just diffuse it all at once. Sometimes it's got to be a slow. Did I answer that correctly? What was your name, by the way?
Mark.
Yes, sir, please.
Another way we're addressing this is actually through one of our solutions, which has already been rolled out. And this is a survey tool called Forte that has been used by Fortune 500 companies for about 30 plus years now to improve their team management. And this is now being applied to therapeutic services, because part of stigma is the fear of disclosing yourself to another individual, putting yourself in a sensitive position where you could be judged. And this applies to your therapist too, if you're struggling with opioid dependence and you're seeking help. The Forte tool allows us to match therapists to the neighbor based upon their communication style. So when that person comes in for their initial appointment and they're not sure if treatment is right for them or whether they're going to be able to work with this group, they're being sat down in front of somebody who can speak their language and communicate with them in the way that's going to break through. And I think that goes a long way to addressing some of the consequences that stigma has created in terms of people help seeking.
On a scale of 1 to 100, where is the development of the wearable technology?
Well, I guess I would have to know what 30 and 60 and 90 looks like. But if I were to take a wild stab at it, I believe we're on the wearable 25% of the way there, only because the sensors already exist. We're not going to reinvent the sensor, but it's how you use it that makes it important. In fact, what we're actually doing is we're building the filter that's going to filter the data to tell you what the data actually means. there's a high likelihood that some of the wearables that are in the room right now on people's wrists are getting half the measurements we need right now to be able to do some of our predictive measures. They just don't know what to do with it. There's so much data hidden inside the data. I was telling somebody the other day, you can take a 10-second clip of me talking, which is probably about 40 minutes, but a 10-second clip of me talking, and what happens is if you stretch that file out and you cancel out my voice, you might hear 30 other things going on in the room, and 2 of them are really important. That's what we're doing. We're taking all that data, we're canceling out the noise, we're looking at those patterns, and letting data science determine what those patterns mean, filtered through the knowledge of Dr. McQueen, Dr. Donlin, Dr. Waltrip, Dr. Wayland Tesh, and the others on our team.
I get it, okay. My apologies, Stephen. I never did this. I did my name.
Yes.
Driving in this morning, I heard that there is an opioid summit, whatever, going on today, right?
Yeah.
Are you guys participating in that? Do you have a presence?
Does
or
anybody
something?
sneak us in the door there? I'd love to go.
We'll work on it. We'll get right on that. The other is,
Yes, ma'am.
I hear the solution, like you're focusing on the end part of this journey. What's being done to actually prevent overdose and addiction to begin with, right? So what can we do to solve the source of the problem, not try to fix it?
Sure, and anybody from my team can jump in at any time. And Lauren, thank you for coming. I appreciate it. It was good to meet you. Don't feel embarrassed. I see the cheeks flushing on my head. It's totally cool, not a problem. So, like I said, anybody can jump in here, but let me address it. So we're not interested in the drug supply. The government and the DEA and all those guys, they can worry about how the drugs are getting in, right? We're worried about our neighbors. So what we want to do is create an ecosystem in the city of Wilmington where we can create a dialogue and a conversation, one, to take away the stigma around opioid addiction, and 2, at some point, it's going to look like education. It's going to look early on, too, intervening and sending fortes to 12-year-olds, for instance, which can be used on the 12-year-old, to find out if they have a precludity or predisposition, thank you, possibly to fall into some of these realms, you know? But yeah, it starts with education. It likely has something to do with blocking some of the supply and the way that drugs are formulated. But ultimately, we're interested in the piece that we're doing, but we want to partner with others and have them be part of the ecosystem also.
To sum it up real quick, it's for neighbors who are willing to recover and taking the steps for recovery, we're making the process most efficient.
Right. And to feel like they're not alone in the journey. I'm sure that's huge too, right?
Yes.
Stephen, you have been.
Yeah, so my question is, how flexible is this product? Is it solely just for the opiate demographic, or is it also for people who are addicted to alcohol or cocaine, right? Where in some communities these are way more destructive than actual
Or meth.
opiates. Yeah, or meth.
That's a great question, and if you could just put a pin in that for a second, I do want to touch just a little bit on your prevention piece, and I think this wraps into it as well. The strength band and the first step have multiple applications beyond just the monitoring of an individual who is already opioid dependent. So how do people become opioid dependent? I think a lot of people have the idea in their head that recreational use generates dependency. But that's actually not the case. Many of the individuals who are dependent come from pain management, from injuries, from pills that they have been prescribed to manage a medical issue. And this is a critical area of prevention. Our technology could be used to monitor individuals during their pain management, after a surgical procedure, after really any other situation in which they're going to be given opiates. This can help to monitor them in the real world so the physician knows what's going on with their use of the opioid and can help to avoid some problems of dependency developing. But this also speaks to the broader applications of this device outside of just the dependent individual. So there's remote trial monitoring as well. The pharmaceutical industry has to run large-scale trials on any drug that they're going to get FDA approved. And these are really costly and they're impaired by compliance issues for their participants, drug use being one of them. Having a monitoring tool that they could implement to see the use of drugs during their trial is a very important goal of theirs. And this goes beyond opioids, obviously, as well. We're sort of viewing opioids as a test case, but the same technology could be applied to stimulants as well. It would be a different biosignature, and it would require additional data learning, but that is a clear next step to move it beyond.
Yeah, I mean, this is huge, right? This is something that you could, give to your kids, right? In the sense of just, try to make sure your teenagers, try to make sure that they're not predisposed to any risky behavior.
Yeah, I think that's going to have multiple applications, Bo. I believe. I'm sorry, I don't mean to cut you off. Appreciate you too, actually. I think it's got multiple applications, but just like anything, you have to be focused. And where we're focusing is in MAT labs, specifically doing methadone treatment, specifically to prevent anoxic brain injury, because they don't want folks to get anoxic. Basically, your brain can be injured if it doesn't get enough oxygen. Seems pretty straightforward, right? But if you're in methadone treatment and it happens, your insurance company's paying for you for life now. And they don't really want that to happen, and nor do we want that to happen to people. So by doing supervised learning during methadone administration, we can see when the methadone hits, separate those frequencies, and say, oh look, they also took this. This is why they're not recovering. Let's get them on the right maintenance drugs so that we can help them to recover better, so that they're in their methadone treatment a year later, which I literally just learned this morning, but how many folks, just so you guys know, MAT is the most effective way to help folks recover from opioid addiction. How many people make it 1 year on MAT?
So on your first attempt to start induction for MAT, about a third will still be enrolled a year later. And just to give you an indication of why it's important that people be retained on this, your mortality rate of having a fatal overdose on opioids, if you are an opioid user, is 1.9 per 50 years before you sought any treatment. So if you had 100 person years, 1.9 people would have died. If you had 100 people over a single year, 1.9 will have died. When you're in methadone treatment, that drops down to 0.4. Post-treatment, if you've left your program for whatever reason, it's 2.1.
That's after relapse.
Yes, exactly. So retaining people in that methadone treatment, exactly, reducing mortality.
We have more questions.
Okay, we have, okay. Oh,
Have you considered leveraging Fitbit data, any of you with Fitbits could be part of your control group, not particularly scientific, and then finding out what it gathers?
Is Eric in the room? I'll see his face. He was here last week. We got an introduction to Garmin. Right? So Garmin is a perfect type of partner for us. So we'd love to work with someone who's developed some of these pieces and already has tons of data backed up or is getting ready to launch something. But yeah, we can work with anybody. Honestly, in the future, where I see this going, and who knows, we're not there yet. In the future, I see any wearable that is of clinical grade being able to pull in these measurements and be able to filter through our software. So our software could live on anybody's wearable and be able to do the same thing. It will not be able to do some of the alerting technology that we're building in. But there's a specific reason why you ask.
Cheap experimentation. Anybody in their team with Fitbit, figure out how you could get a download of your data in a usable form, as usable as you could, and just play with it and see what surprises you find.
So one of our data scientists is shaking his head. So we're doing that now with we're working with a few companies right now, two in particular, Balancel and BioStrap, and we're actually pulling their data directly from the wearable into Tableau, and we're doing data science on it right now. So some of that's already beginning. In fact, Matt, you could present your biometric signatures right now. Well, I don't ask you to do that. But yeah, we literally sitting down this yesterday working on this. So yeah, that's a fantastic question. Thank you so much.
I
I go back to prevention because what Chris was saying, it's important because you guys are going to have some unique data. You're going to have field data and prescription. I really like the idea to the doctors and the wearables with the drugs because some of that stuff you could see the doctors are prescribing wrong. See, to me, that should be drugged back so doctors don't do that part. But the prevention part where I was going also is that information could go back into the, I hate to say the government side, and create the laws to fix some of the things up front. So you really need to take this data that you have so you can drive it back because you're going to have unique information, field data, live data that people don't get.
So to your point, if I could, and I'll try to be very brief and construct to what you're saying. So we're actually going to be having Forte data coming in, which is French for one strength. So one strength band, and first step, right? So Forte data is psychometric data and communication data. Then we'll have raw data from that looks like medical data and prescriptions, all that come in. And then we're going to have biometric real-time data all feeding the same algorithm, refining it. So when we're done, we'll have the largest multifaceted database of its kind anywhere. And in fact, I can promise you and guarantee you today that the data that we have today with partnership with Forte, nobody has that. Period.
See, and I think that's one.
And that is the magic right there. It is magic. And you know, I hope because our mission is to help our neighbors, is to work with other institutions and help advance their research too. Because ultimately, my goal is for us, and this is collectively shared, to have a healthier population. Like why, in a country so beautiful and so lovely as this, and a city so beautiful as Wilmington, why is there such disparity in the quality of our care? Why can't we scale good outcomes, great outcomes? Technology has the capacity to do that, but technology is still just a tool. If we use it for the good, it will do good. If we use it to make money, it will make money. But I believe we can do well by doing good. But let's start out with the neighbor in my first, profits will come later. So anyway.
I'm not even talking about profit, I'm just
Oh, no. I'm just saying because it's something that's, yeah, it was nothing to the comment you said. I just feel so strongly about that. I feel the need to state it because I come from the world of healthcare where everything was profit driven. And I ran outpatient imaging centers where we were charging an exorbitant amount of money for things that should not have been expensive.
Anyone else? Brendan, last one.
All right. Can you talk a little bit more, David, about your partnership strategy and just in terms of identifying neighbors or finding neighbors to support around that? And I'm just curious, longer term, like, where do you see kind of OpiAID, like, where's the line between OpiAID kind of helping neighbors and partners versus leveraging your technology? Does that make sense?
Could you, I'm going to come back a little bit. Go ahead. I'm not going to see. I don't know how often this happens.
No, I was thinking you talked about strategy.
Hold on, everyone.
This is where our mics are helpful. This is where mics are awesome.
You're going to have to repeat the question then, okay? You're going to repeat the question?
Yeah, so the question was, this is the last question, I'm sorry to keep you guys here. The question was, what's our partnership strategy? How do we get this to the neighbors? Is that right? Awesome. So our partnership strategy is to work with the groups that are most interested in helping the neighbors. So we first invite them to the table to get their feedback. While they're giving us feedback, they're actually telling us how to bake the cake that they want to buy. Does that make sense? So they sit there and they're like, well, this will never be used if you don't do this. And I'm like, well, that seems interesting. Why do you say that? Well, we would only use it here if you did this. Well, it sounds like if I built it like that and it fell within what type of budget, you guys would be buying it, right? And what would you do with that if you were to have that type of tool? So some of that customer discovery is happening right there at the table where we're all brainstorming and working together, this ecosystem. So it looks like MAT programs in whatever form or fashion that is, and through ecosystems like Project OBOT, OBOT. You know, that's a very interesting program. If we were to get in there, we'd get access to NCHIE data, North Carolina Health Information Exchange, 300 plus hospitals, plus we'd be part of the recovery platform and connected to UNC. That's super powerful. So just starting the dialogue is really powerful. I have several ways that we're going to get to market. The neighbors, they come through the partnership. I'm not chasing neighbors. And in fact, none of my neighbors will ever pay for this wearable. If you want the wearable, you'll be able to get it through your provider. And if you really just want to buy that wearable, you'll be able to do that too and give it to a family member.
Which We have a few neighbors actually in our team actively participating. And we also attend groups at treatment centers where we talk to people and see what resonates with them.
All right, with that, our time is up, and thank you, Chief.